We'll wait for a few more minutes. Once the judge joins in, we'll start. Ma'am, can we start?
Yes, we can.
Uh, Good evening, everyone. Today's judge is Dr. Mona Desai. We are very thankful for you for being here. Thank you, ma'am, for being here. So, should we start the presentation?
Yes.
Okay, so for the first presentation, we have Dr. Chirag Chaudhary. Uh, are you ready?
Yes, ma'am.
Yeah. Okay.
Okay.
Good evening, ma'am. My topic is a randomized comparison of three different transducer approaches for USG guided IJV cannulation. Next slide, please. USG guided IJV cannulation is preferred in critical care and OT setup because of advantages over traditional landmark approach. So there are certain complications which are seen in both approaches, which are 5 to 19% arterial puncture, pneumothorax, hemothorax, air embolism, or catheter embolism. So to decrease the complications, there are certain approaches while doing ultrasound guided IJV cannulation. There are three approaches. Most commonly used is short axis approach, in which transducer is placed transversely to the IJV. In this approach, we can see the artery and vein simultaneously. In long axis approach, the vessel is placed perpendicular to the probe. So in long axis, we can see a tip length of the needle piercing through the IJV. So both approaches have their advantages and disadvantages. To overcome these advantages, there is a third approach which is called oblique axis. So oblique axis. Next slide, please. Okay. My aim of the study is to compare all three approaches of first needle pass success, cannulation time, and complications associated with those. Next. My materials and methods, we took 210 patients and randomized them to three groups, 70 per each group. So for each axis use, we measured the following observations: neck circumference, IJV diameter, first needle pass success rate, cannulation time, and complications associated with. So these are my three approaches: short axis, long axis, and oblique axis. And these are the ultrasound images. We can acquire all three approaches. Next. We took patients which didn't fit in exclusion criteria, like infection sites, cutaneous erosion, history of IJ cannulation in less than 72 hours, or subcutaneous emphysema with cervical extension, or severe coagulopathy. We excluded those patients and included other patients with written informed consent. Next. Okay, these were the observations we get. So there are those no differences between our demographic data. We saw the we which was 97 percentage, and number of items were less in that view, and cannulation time was also less in that view. So next, we acquired these results and found that next, please. These are the results. We found a mean cannulation time 30 seconds in oblique axis view, which was less than two other views. The complications were also less in oblique axis views, which were two due to mechanical trauma. And oblique axis view, so we found that oblique and short axis view, there is high needle pass success rates, dash cannulation time, and in long axis view, there was high chances of arterial cannulation. So, and we also found posterior vein wall puncture, which was high in long axis. Because of we have a tendency to remove the ultrasound probe once we have cannulated the IJV. So because of removal of probe, the elastic recoil of IJV tends to get punctured at the posterior side. Next, please. So there are two other studies which compared all three axes, and Bartlori et al. Found that there is high first chance pass success rate in oblique axis view, which is better than other two views, and cannulation time was also in less in oblique axis view, which is comparable to our study. Next. So in conclusion, we found that oblique axis view is superior to all these two views in terms of complications, less complications, and less type, and high first needle pass success rate. Next, please. These were my references, and thank you, ma'am.
What was the aim of your study?
Yes, ma'am.
What was the aim of your study?
Madam, we compared three different approaches: short axis, long axis, and oblique axis, and compared complications associated in each group. We found we want to know that which axis, which approach takes less time, and which approach has less complications associated with it.
In how many patients you encountered the complications?
Madam, there were 10 patients. Out of 10, 2 were in oblique axis view, and 6 in long axis, and 2 were in short axis view.
Okay, and how
which
did
were
you
arterial
calculate?
cannulations. And,
How did you calculated the data?
Data was calculated by SPSS software, ma'am.
Okay, okay.
Okay, thank you.
So next we have Dr. Dimple Sadaria. Are you ready? Dr. Dimple Sadaria.
Hello? I'm able. Hello? Somebody sir? Hello?
Yes, we can hear you.
Hello? Okay. Hello? Good afternoon, everyone. I'm Dr. Dimple Sadaria from BJ Medical College, second year resident. My study is comparison of analgesic effect of intramuscular nalbuphine and tramadol in post-operative pain. The relief of pain has been a major reason for the development of healthcare. Pain is recognized by the International Association for the Study of Pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Postoperative pain is currently treated with two classes of drugs. NSAIDs, non-steroidal anti-inflammatory drugs, which act by inhibiting prostaglandin synthesis, and achieve the analgesic and anti-inflammatory action. And second one is a narcotic analgesic, which acts directly on the central nervous system opioid receptors, but can cause drug dependence, respiratory depression, constipation, nausea, vomiting, sedation. Opioids have long been the mainstay of therapy for the treatment of acute postoperative pain, especially for moderate to severe pain. However, the use of new agonists like morphine may result in serious side effects like pruritus, urinary retention, nausea, vomiting, and delayed respiratory depression. So there is a new approach which is looking to use a newer opioid for the analgesia. Now, nalbuphine and tramadol are the drugs which we had compared here for their efficacy in postoperative analgesia and the side effects. The nalbuphine is partial agonist antagonist having agonist on kappa receptors and antagonist or partial agonist on mu receptors. While tramadol is centrally acting analgesic which has weak affinity for the central opioid receptors. Current study is comparing this efficacy of nalbuphine and tramadol for control of post-operative pain as well as side effect profile after giving their intramuscular doses. This is pain pathway. Aims and objective. The main aim of our study was to evaluate the efficacy and safety of IM nalbuphine and IM tramadol for the post-operative analgesia. To compare the effectiveness and to note the onset of action of IM nalbuphine and tramadol, the total duration of post-operative analgesia, quality of analgesia, time of requirement of rescue analgesia, comparison of effects on hemodynamic parameters and side effects of intramuscular nalbuphine and tramadol, materials and methods, subject selection criteria. We have included the patients aged 18 to 65 years, ASA grade 1 to either sex, and exclusion criteria when patient refusal, patient having cardiac respiratory hepatic failure, psychological coagulation disorders, chronic pain medications, using chronic pain medication, allergy to medication, or a history of substance abuse or emergency surgical procedures. Methods. After approval by hospital ethical committee, obtaining the written informed consent by patient's relative, study was done. 60 patients aged 18 to 65 years of either sex, ASC grade 1 and 2, scheduled to undergo the elective surgeries under general anesthesia was included in the study. 60 patients was randomized based on computer-generated random numbers in two groups. Nalbuphine group dose 0.15 mg per kg group N, and tramadol group T 2 mg per kg intramuscular doses. These analgesics were given 30 minutes before the extubation. On the day of surgery, NBM is maintained and explanation of GA procedure surgery is done and informed consent taken. Monitoring intraoperatively blood pressure, pulse, respiratory rate, temperature, SpO2, ECG, NIBP, ETCO2. Pre-medication given, injection glycopyrrolate 0.004 mg per kg, injection ondansetron 0.15 mg per kg. Patients divided in two groups. Group N given nalbuphine IM and group T given tramadol. These were given 30 minutes before extubation. Pre-oxygenation done, induction done with thiopental sodium 4 to 6 mg per kg and scopolamine 2 mg per kg IV. Intubation after proper laryngoscopy, proper size endotracheal tube intubation done, and after checking bilateral air entry, ET tube fixed and patient ventilated with 100% oxygen. Anesthesia was maintained using 50% oxygen, 50% nitrous oxide, and 1% CO, and along with a non-depolarizing muscle relaxant. Monitoring heart rate, systolic blood pressure, diastolic blood pressure, and SpO2. All parameters were recorded at the following stages. Reversal of anesthesia. All patients were reversed after onset of spontaneous respiration with injection glycopyrrolate 8 microgram per kg and neostigmine 0.05 mg per kg. Extubation after satisfying before extubation 30 minutes before this analgesics were given. After satisfying extubation criteria, oral and endotracheal suction done and patients extubated. Analgesic effects were evaluated in group T, who were given the tramadol, and group N, who were given the nalbuphine intramuscularly. Post-operative pain assessed for 24 hours after surgery. Pain assessed using the VAS score. 0 means no pain and 10 means worst imaginable pain. Good pain relief is defined when VAS is less than 4. Once this score is reached, rescue analgesic injection diclofenac sodium 2 mg per kg IV was given when VAS is more than 4. Pain was assessed using visual analog score. This is a effect of on a heart rate. This shows that there is no significant difference in the heart rate perioperatively in both the groups, except at the 6 hour where heart rate was slightly higher in group tramadol. This is systolic BP. The graph shows no significant difference also in a systolic blood pressure in both the groups. P-value is less than P-value is 0.0036.
20 seconds left.
Okay. This is diastolic blood pressure and VAS post-operative. VAS score in group T is higher at 6 hours and at 8 hours in group N have higher value with P-value less than 0.05. After extubation and immediate post-operative period, VAS score is comparable. Post-operative complication. Conclusion. We conclude that IM nalbuphine is safe and effective alternative for the relief of moderate to severe post-operative analgesia compared to IM tramadol, as well as the side effects are more with tramadol, like nausea, vomiting are higher in the group T as compared to group N. And these are our references. Thank you.
Nalbuphine is which group of drug?
Tadufin is a
Which group of
opioid
drug?
directly acts on the central nervous system. Opioid agonist.
Okay.
So next presentation is of Farista Paper. Are you ready?
Yes, ma'am. Good afternoon, everyone. I'm Dr. Farista Pegu, second year anesthesia resident, presenting a study on a comparative study of epidural morphine sulfate soak gel form and morphine sulfate instillation in the management of post-operative pain following lumbar spinal fixation surgery. Next slide, please. Hello. Hello.
Hello.
Hello. Yeah. My introduction, lumbar laminectomy surgeries are done to alleviate pain, but the surgery itself causes significant post-operative pain and discomfort, leading to prolonged hospital stay and delayed return to normal activity. Uncontrolled post-op pain hampers the wound healing, post-op morbidity, delayed recovery of pulmonary function, thromboembolic complications due to immobility, and to minimize such undesirable side effects, epidural analgesia is an effective and safe method in surgeries of the spine. Next, please. Aims and objectives are to compare the analgesic efficacy, to evaluate the post-op analgesic effect, to evaluate the requirement of rescue analgesia, and to study the side effects of gel form morphine, to evaluate the effect of gel form on post-operative hemodynamics. Next slide. Study design was the prospective randomized trial. Study population were 60 adult patients undergoing elective lumbar spine surgeries were randomized into two different groups. Verbal and written consent were taken. The inclusion criteria 20 to 60 years of both sexes, ASA physical status of grade 1 and 2, elective lumbar spinal surgeries under GA. Exclusion criteria was a known case of hypertension, diabetes mellitus, renal disease, cardiac disease, seizure disorder, and bleeding disorders. Next slide, please. Local infection, previous spine surgeries, accidental dural tear while undergoing laminectomy, allergy to the study drug, case with lesion extending to cervical, thoracic, and sacral vertebra, ASA grade 3 and 4. Next slide, please. Method of study. The 60 adult patients undergoing elective lumbar spine surgeries were randomized in two groups, 30 in each group. In group Z, 5 into 1 piece of absorbable gel form soaked in 5 mg morphine sulfate diluted in 0.9% saline up to 5 ml was placed in epidural space, and in group I, gel form soaked in saline was placed in epidural space, and 5 mg of morphine sulfate was diluted in 0.9% saline up to 5 ml was instilled over the intact epidural space. Subjective pain measured by the VAS on a scale of 0 to 10, with 0 representing no pain and 10 representing the worst imaginable pain. All patients were acquainted with VAS preoperatively. Next slide, please. Statistical method. Descriptive statistical analysis had been carried out in the present study. Results on continuous measurements are present on mean standard deviation, and categorical measurements were present in number percentage. P-value less than 0.5 was considered statistically significant, and unpaired t-tests had been used to find the significant incidence of side effects between two groups. Next slide, please. This is the chart showing the demographic details. Total of 60 patients of both sex and ASA grade 1 and 2 were enrolled in this study. Both groups were comparable in respect to age, height, weight, gender, duration of surgery, duration of anesthesia, and type of surgery. Next slide, please. Heart rates were recorded in group 1 were much as compared to group Z at most time interval, and this association was found to be extremely and statistically significant. Next slide, please. Mean arterial pressures were lesser in group C as compared to group I across all the intervals. However, this became extremely statistically significant only after 5 hours up to 48 hours. Next slide, please. Mean VAS score was 0 in immediate postoperative period in both groups, but increase in group I as compared to group Z henceforth. The difference in mean VAS at rest was statistically significant. Next slide, please. Mean VAS score at movement was similar in both groups in immediate post-op period by increasing group I as compared to group Z henceforth. The difference in VAS was also statistically significant. Next slide, please. This is a slide show comparison graph between the VAS score at rest and a VAS score at movement. Next slide, please. Patients in Group I received a rescue anesthesia much earlier than in Group Z, and this difference was extremely and statistically significant. Next slide, please. Mean consumption of rescue analgesia, that is injection diclofenac 75 mg IV in 48 hours, are greater in Group I as compared to Group Z, and this association was found to be extremely and statistically significant. Respiratory rate SpO2 were similar in both groups with no significant difference. Next slide, please. Sedation score were found to be similar in both the groups with no significant difference. Next slide, please. Total of 10% in Group Z recorded pruritus, where in Group I 13.2% recorded pruritus. About 6.6% in Group Z and Group I had nausea. There was no case of bradycardia, respiratory depression, and hypotension in Group Z as well as Group I. Now coming to the conclusion, pain management will always be a crucial part of perioperative care and has an important role to play in postop morbidity. Epidural morphine acts on the dura and not on the spinal roots, and therefore does not cause motor blockage. Gelform gets absorbed in 4 to 6 weeks compared to 8 to 10 weeks for the microfibular hemostatic response. The fact that the Gelform is already being used during lumbar laminectomy surgeries makes it a good choice, as it's used for drug delivery device for post-op pain. It was observed that the mean VAS score at rest as well as in movement in Group Z remained less as compared to Group I at most of the time intervals. This indicates that a patient in Group Z had less pain as compared to Group I. For a VAS at p-value was less than 0.1, and on movement p-value was less than 0.5, which is statistically significant. The time of the first rescue analgesia is 36 hours in Group Z, whereas in 9 hours in Group I. Total analgesic requirement was more in Group I as compared to Group Z. Next slide, please.
36.
Next slide. Next slide, please. Systolic BP, diastolic BP, and mean arterial pressure were lower in Group Z as compared to Group I. Respiratory rates and sedation scores were mostly similar in two groups with no significant difference. Total of 10% in Group Z reported pruritus, where in Group I 13.2% reported pruritus, about 6.6% in both Group Z and I had nausea. Next slide. After analyzing the study of the result, it can be concluded that epidural administration of morphine using Gelform as a vehicle for sustained release of morphine is safe and effective method for post-op analgesia and lumbar spinal fixation surgery, and results in better hemodynamic, prolonged duration of analgesia, and reduced requirement of rescue analgesic as compared to epidural instillation of morphine. However, both the techniques have similar and minimal side effects. And my next slide is on the next slide. These are the references. Thank you.
So, Parisa,
Yes, ma'am.
what was the aim of your study?
Ma'am, my aim was to study the analgesic effect of compare the analgesic effect of the Gelforms of morphine and direct instillation of morphine in the epidural space, and to compare the hemodynamic parameters in both the patients.
Is there any reference that any allergic reaction with the gel form?
Ma'am, 10% of the patients were in Group I, as Group Z has reported pruritus. Ma'am, other than that, there were not any allergic reaction.
Okay. And what are the different methods of pain relief, acute pain relief?
Ma'am, we can give direct IV.
Yes.
IV pain relief and neuralgia methods such as epidural analgesia. And ma'am, in my study, you asked me.
Okay.
So next is Dr. Hetal Chaudhary. Are you ready?
Yes, ma'am. Yes, ma'am.
Good evening, ma'am. I am Dr. Hetal Chaudhary, a third-year resident from Bija Medical College, IKDRC. Today's my presentation topic is comparative study of dexmedetomidine and butorphanol as an adjuvant to ropivacaine in brachial plexus blocks for arteriovenous fistula surgeries. Next. AV fistula surgery. AV fistula is surgically created passageway between artery and vein created for hemodialysis in patient with end-stage renal disease, done under general anesthesia, regional anesthesia, local infiltration. Brachial plexus block improve the vasodilatation, which make vascular anastomosis much easier. Increase post-surgical fistula blood flow. Supraclavicular approach, easiest and most effective way. Next, please. These are the various approach of brachial plexus: interscalene, supraclavicular, infraclavicular, axillary. These are the anatomy of brachial plexus. Next, please. USG guided needle insertion under real-time visualization. So navigate the needle away from the sensitive anatomy like pleura, blood vessel, etc., thereby avoiding the complication related to procedure. PNH used for confirmation of now bundle location. Local anesthetic ropivacaine, a long-acting amide local anesthetic is used, which are less cardiotoxic than bupivacaine. Adjuvant use buterphenol, synthetic opioid, a morphine type of synthetic agonist antagonic opioids. Dexmedetomidine is a highly selective alpha 2 agonist. Next. Study was designed with the aim to compare the efficacy of adding buterphenol and dexmedetomidine to a ropivacaine 0.5% in supraclavicular block in a term of onset and duration of sensory block, time for the first dose of rescue analgesia in post-operative period, duration of motor block, hemodynamic parameter, sedation and other side effects. Next. These are my material and method. After ethical committee approval and informed written consent from patient, a prospective randomized double-blinded clinical trial in 60 adult patients of either sex suffering from end-stage renal disease with ASA 3 and 4 are selected for creation of AV fistula under USG and PNS guided brachial plexus block in supraclavicular approach. These are my exclusion criteria: age less than 18 years and age more than 60 years, history of hypersensitivity reaction to local anesthetic drug. Third one is peripheral vascular disease, neuropathy involving upper limb. Fourth is infection at local site. Fifth, coagulation disorder. Next. There are two groups, group RD and RB. Injection ropivacaine 0.5% 30 ml. In group RD plus injection dexmedetomidine 0.5 microgram per kg. In group RB, injection buterphenol 2 mg added. Pre-anesthetic preparation, psychological reassurance about the procedure and post-operative analgesia, thorough clinical evaluation of the patient, and pre-operative hemodialysis and post-HD morning coagulation profile and serum potassium level monitor. Morning dose of scheduled medication for associated systemic illness and starve overnight. Next. Uh, 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 Peripheral intravenous line was secured with 20 gauge intravenous cannula. All ASA standard monitoring was applied. Patient in supine position with a hand adducted to the side, head turned to a 45-degree to opposite side, a sandbag kept under the shoulder and ring below the occiput. Next. Under strict aseptic precaution, local infiltrated at the site of puncture. A group of 3 to 4 hypoechoic circle lateral to the subclavian artery pulsation was visualized. Needle advancement along the long axis of probe from lateral to medial. Confirmation of needle position by the PNS. Once a drug injected into divided dose of 50 ml each after negative aspiration. Drugs paired were visualized under USG. Next. Next, please. A sensory block was assigned using 3-point scale. Motor block was assigned using Bromley scale, and perioperative sedation was rated by using the Ramsey sedation score. Next.
1 minute left.
Next, please. Post-operative intensity of pain was measured using 10-point visual analog score, VAS score. Parameter observed. Intraoperatively, onset time of sensory and motor block, sedation by Ramsey sedation score, hemodynamic parameter, and side effect. Post-operatively, duration of motor block and duration of analgesia. Next. Observation and result. Next. In our study, we observed that the onset time for both sensory and motor block were shorter in group RD than in group RB, but the difference was statistically insignificant. Next. The duration of motor and sensory block was significantly prolonged in group RD when compared to the patient in group RB. Next.
Time up.
In our study, we conclude that use of lower dose of dexmedetomidine 0.5 microgram per kg as a adjuvant with ropivacaine 0.25% in supraclavicular block for AV fistula surgery in ESRD end-stage renal disease patient prolong the duration of sensory and motor blockage post-operatively, better analgesia and satisfactory sedation during procedure. Thank you, ma'am.
What are the effects of metabolism of dexmedetomidine in end-stage renal disease patients?
Ma'am, there is a longer duration of effect in end-stage renal disease patient, ma'am.
Is there any requirement of reducing the dose?
Ma'am, lower dose 0.5 microgram per kg is used in our study, ma'am.
Okay, fine.
Okay, thank you.
Next, we have Dr. Kendrell Solanki. Are you ready? Dr. Kendrell Solanki?
Yes, ma'am.
Okay.
Yes, ma'am. Good afternoon, ma'am. Myself, Dr. Kinjal Solanki, resident doctor from BJ Medical College. So I'm going to present a paper on use of ketamine hydrochloride nebulization for attenuation of post-operative sore throat. So post states that post-operative sore throat, which is one of the most undesirable subjective complaint due to inflammation of tracheal mucosa following endotracheal intubation. So to overcome those, various pharmacological and non-pharmacological methods were used, and ketamine is shown to be a very good agent to reduce post-operative sore throat. Next, please. So coming to the aim, my aim is to compare the incidence of post with and without the use of ketamine nebulization. And my objectives are to compare the incidence of post-operative hoarseness of voice and cough, to evaluate the effect of nebulization on the hemodynamic parameters and the oxygen saturation, and to study any untoward effect due to systemic absorption of the drug. Next, please. So in methodology, we did prospective randomized trial and we selected 60 patients for our study. After approval from the hospital ethical committee, and verbal and written consent were taken from all the patients. And we included the patients whose age is between 18 to 60 years, AC grading 1 and 2, MPG score 1 and 2, and who are chosen for elective surgeries. And we excluded the patients who have difficult airway and who are compromised, whose safety is compromised in due to systemic absorption of the nebulized drug. So first of all, we checked all preoperative anesthesia checkup was done for all the patients. After that, we prescribed tablet lorazepam 1 milligram orally a night before surgery to all the patients. On the day of OT, after securing IV line, all the basic parameters were attached like ECG monitor, BP, and pulse oximeter. And hemodynamic parameters were noted before nebulizations. After that, patients were selected for the study group were nebulized with the ketamine hydrochloride 50 mg in 5 ml sterile water for about 5 minutes, and all the hemodynamic parameters were noted after nebulization, before induction, and before incision. Volume of air required for endotracheal cuff inflation was comparable in both the groups, which are ranging from 5 to 7 ml. An injection paracetamol 15 mg per kg intravenous was given as a rescue therapy for pain. And in the post-operative period, we monitored post-operative sore throat, cough, and hoarseness of voice in our study and control group. So this slide is showing the grading of sore throat, cough, and hoarseness of voice. After taking all the data, next please. Data were analyzed using GraphPic t-test and Medcock software. P-values less than 0.05 were considered statistically significant. It is very difficult to demonstrate statistical significance in a very small sample. So we compared the values by combining the incidence of nil with the mild sore throat and nil with the moderate sore throat. And the only limitation of our study is not measuring the serum ketamine and norketamine levels to rule out the systemic effect. So coming to the results, first slide is showing demographic data which is comparable in both the groups. Next slide. So this table is showing comparison of incidence and severity of post-operative sore throat at different intervals. There was statistically significant reduction in the incidence of sore throat in study group after extubation as compared to control group. And after 6 hours, study group had no sore throat at all, but few patients in control group had mild symptoms. Next, please. Table 3. Next, please. This table is showing comparison of hemodynamic changes. So from this table, we can easily state that there is statistically significant increase in the heart rate and mean arterial pressure was seen in study groups when pre-nebulization readings were compared with those of the post-nebulization. But as we took care of attenuation of pressure response at intubation by injection fentanyl and propofol, change in hemodynamics were non-significant after induction and then throughout the surgery. Table number 4. Next, please. So this table is showing any untoward effects occurs due to systemic absorption of the ketamine. So there was no any other untoward events occur due to ketamine absorption except delirium was noted in one patient after nebulization, but it was subsided when patient came out of the anesthesia at the end of surgery. And we monitored SpO2 from beginning of the nebulization to the end of the surgery. And there was not any time fall in the SpO2. Next, please. Next, please. Last two table is showing comparison of incidence and severity of post-operative hoarseness. Next, please. And cough. So from these two tables, there was significantly low incidence of hoarseness of voice and cough in study group for 6 hours after extubation as compared to control group. And after 6 hours, with the permission of sips of water, cough and hoarseness were relieved in all the patients. Next, please. So to conclude, preoperative ketamine nebulization is very effective for attenuation of incidence and severity of post, hoarseness of voice, and cough during early postoperative period in patients receiving general anesthesia with tracheal intubation and with reversible hemodynamic changes and without any significant side effects. So I included the references at the last. Thank you, ma'am.
So what are the other methods of reducing postoperative sore throat?
Okay. And post-operative sore throat can be reduced by doing gargles, like betadine gargles, prescribing them.
What other measures we can take during induction?
At the time of induction, first of all, we can, if any injury of vocal cords or trachea is found, then we can give steroids like dexamethasone to the patient.
First of all, atraumatic intubation, proper size tube, proper cuff pressure.
Yes, ma'am.
Okay.
Yes, ma'am.
Fine.
Okay. Thank you, ma'am. Thank you, ma'am.
Next, we have Dr. Leary Kunti. Are you ready?
Yes, I am audible.
Yes.
While presenting, kindly keep your webcams on.
Good afternoon, ma'am. Myself, Dr. Kutiliri, third year resident. My topic is comparison of analgesic efficacy of levobupivacaine alone versus levobupivacaine with ketamine in subcutaneous infiltration for post-operative analgesia in lower segment cesarean section. Next slide, please. Next, please. The effective relief of pain is of utmost importance to anyone treating patient undergoing surgery, and it has significant physiological benefits. Hence, monitoring of pain relief is increasingly becoming an important post-operative quality measure. Post-cesarean patient has an additional compelling reason to be provided adequate pain relief so that early ambulation helps in breastfeeding and care of newborn. In addition, mobilization is a key factor in attending the risk posed by exaggerated thromboembolic phenomenon in pregnancy. Multimodal analgesia is an established technique for controlling post-operative pain as it combines multiple drugs with different duration of action by different routes of administration like intramuscular, intravenous, rectal route, perineural infiltration are used to provide effective and safe analgesia. Levobupivacaine is an amide local anesthetic and pure as enantiomer of bupivacaine with lesser cardiotoxicity and neurotoxicity. Next slide, please. Pain transmission also occur by sensitization of spinal cord by glutamate and aspartate in N-methyl D-aspartate receptors. Ketamine as an NMDA receptor antagonist act by inhibiting NMDA receptor on the postsynaptic membranes of the posterior horn of spinal cord. Thus, it inhibits the transmission of pain from spinal level to the central nervous system and consequently suppress the hyperalgesia and allodynia. My aims and objective was compare the local anesthetic efficacy of levobupivacaine alone with that levobupivacaine and ketamine in post-operative analgesia following cesarean section. Material and method. After obtaining written and informed consent, we concluded a randomized study in 42 patients and compared the efficacy of levobupivacaine and levobupivacaine with ketamine in subcutaneous infiltration. Patients were divided into two groups with 21 patients in each group. Next slide, please. The patient selection and exclusion criteria. The antenatal mothers of age group 18 to 35 years with BMI 18.5 to 40 kilogram per meter square scheduled for cesarean section under spinal anesthesia were included in the study. The patients were excluded from the study are who did not give a valid consent, who have allergic to study drugs, eclampsia, gestational diabetic, cardiopulmonary disease, skin disease, coagulation disorder, and renal or liver disease. Next slide, please. Pre-anesthetic evaluation. Pre-anesthetic evaluation of all patients consisting of detailed history, physical examination, and routine investigation. A written informed consent was taken after proper counseling. Anesthetic protocol. Pre-operative preparation. Patient will be explained about the procedure and informed consent will be taken. IV line will be secured. Preloading will be done with injection ringer lactate 10 to 15 ml per kilogram IV. Pre-operative vitals were noted. Next slide, please. Pre-medication with given with injection glycopyrrolate 0.01 milligram per kilogram and injection ondansetron 0.1 milligram per kilogram. Anesthetic technique. All preloading fluids and drug were stored and administered at room temperature. Subarachnoid block was instituted under strict aseptic antiseptic precaution in sitting position in L3 L4 intervertebral space with 25 gauge spinal needle with 2.5 ml of 0.5% hyperbaric bupivacaine. Onset of sensory block was assessed by pinprick method and motor block was assessed according to modified Bromage scale. Surgery was allowed once desired sensory block and motor block of Bromage 3 was achieved. Wound infiltration. At the end of surgery before screen closure, study drug would be infiltrated at local wound site before wound closure. Group A, subcutaneous surgical wound infiltration with solution of 0.5% levobupivacaine at the dose of 2 mg per kilogram at maximum of 150 mg diluted with normal saline to a total of 30 ml. And group B will receive the subcutaneous infiltration with 0.5% levobupivacaine with ketamine 1.5 mg per kilogram with diluted with normal saline to total volume of 30 ml. Next slide, please. Assessing the visual analog score. Time of first request for post-operative analgesia when VAS score is greater than or equal to 4. When VAS score is greater than or equal to 4, injection tramadol 100 mg IV was given and that time was calculated as total duration of analgesia. Next slide, please. Observation and results after studying, we observed that a p-value of less than 0.05 was significant and greater than 0.05 was non-significant. We observed that the both groups were comparable with respect to demographic data. Patient in group A had higher mean VAS score than group B at all time intervals, and statistically significant difference were noted in the 1, 4, 6, 12 and 16 hours post-operatively. Here are my result for mean VAS score. There is a mean time to first rescue analgesia and total consumption of rescue analgesia. Next slide, please. Next, please. Discussion. Pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Post-operative pain leads to pain discomfort, prolonged recovery, higher health cost. In post-operative, poor pain control may interfere with ambulation, breastfeeding, and early maternal bonding with infant. In our study, we observed that in group B, means levobupivacaine plus ketamine, experience a post-operatively pain-free period of 360 minutes, whereas in group E, levobupivacaine alone, the patient may experience pain-free period of 228 minutes. Next slide, please. The overall VAS score in our study group were higher in group A, that is levobupivacaine alone, and the mean VAS score was decreased in group B with levobupivacaine plus ketamine. The total rescue analgesia consumption in group B is less, which is 61 milligram. In group B, levobupivacaine alone, it is 100 milligram. Next slide, please. The conclusion, the combination of the subcutaneous infiltration with ketamine and levobupivacaine provides a superior quality of post-operative analgesia than levobupivacaine alone with minimal side effect. Here are my references. Thank you, ma'am.
How you have calculated the data?
For demographic data, we were using the chi-square test, and for the comparison of the quantitative, we using the student t test.
Okay.
Thank you, ma'am.
Next, we have Dr. Mahajbin Pathan. Are you ready?
Yes.
Kindly keep your webcams on during presenting.
Good evening, ma'am. Myself, Mahzabin Pathan, second year resident from BJ Medical College. Today, my topic is comparison of dexmedetomidine and clonidine as adjuvant to.
I don't get your voice, Mahzabin.
What, ma'am? Pardon, ma'am?
I don't get your voice.
Hello? Am I audible?
Hello.
Hello?
No.
Hello? Hello?
Hello.
Keep your mic nearer.
Hello.
Hello.
Hello. Hello, ma'am. Am I audible? Hello.
Very slow voice is coming.
Can you keep your
Hello.
little close to you?
Hello.
Be close to your mic.
Hello.
Okay, go ahead.
Hello.
Hello.
Good evening, ma'am. Myself, Mahzabin Pathan, second year resident from BJ Medical College.
Yes.
Today, my topic is comparison of dexmedetomidine and clonidine as adjuvant to ropivacaine in supraclavicular block. Next slide. Regional anesthesia techniques are an important part of armamentarium of anesthesiologists. It is safe and has advantage of early ambulation and prolonged post-op pain relief. It avoids an unwanted effect of anesthetic drugs used during general anesthesia, pressure response of laryngoscopy, and tracheal intubation. Brachial plexus block are amongst the most commonly preferred peripheral neural block for upper extremity owing to their higher success rate and their ability to provide prolonged post-operative pain relief. Here, ropivacaine is been used. It has better safety profile compared to bupivacaine as it is less cardio depression and central nervous system toxicity. Potential clinical advantage during neural blockade when large volumes are used. Effect of plain local anesthetic is short-lived and often lasting only for 6 to 8 hours. So adjuvants have been used with local anesthetic in brachial plexus block to achieve quick, dense, and prolonged block. This study was carried out to evaluate the effect of 0.5% ropivacaine in combination with clonidine as compared to 0.5% ropivacaine with dexmedetomidine in supraclavicular block in upper limb surgeries in terms of onset, duration of sensory block, and duration of analgesia. Next slide. My aim was to evaluate the effect of ropivacaine with clonidine and compare it with ropivacaine with dexmedetomidine in brachial plexus block through supraclavicular route. Objectives were to compare the duration of sensory and motor block in both groups, to compare the duration of analgesia in both groups, hemodynamic parameters, and if operative complications. Next slide. A randomized prospective and control study was done. 60 patients were divided in 2 equal groups. Inclusion criteria were written informed consent given by patients. Patients aged 15 to 65 years, ASA grade 1 to elective emergency unilateral upper limb surgeries. Exclusion criteria age less than 15 years or more than 65 years, ASA grade 3, 4, 5. Patient refusal, patient having hypersensitivity to local anesthetic drugs, hemodynamic instability, local infection, patient having
Mahzabin, I don't get your voice again. Hello.
Hello? Next.
Hello.
Hello?
Can
No,
keep
you are
your
not
mic
audible.
closer to you?
Hello.
Hello?
All the patient underwent pre-anesthetic checkup before surgery, and all the routine and specific investigations were noted. Patients were kept electively nil per oral for 6 hours before surgeries. On the day of surgery, written informed valid consent was taken, and prior to operation, patients were explained about the procedures. Standard monitors like ECG, NIBP, and pulse oximeter were applied, monitoring done, IV line secured, and pre-medication given, injection midazolam and ondansetron. Next slide. We use a classical technique. After placing the patient in dorsal recumbent position with head turned away from site of injection, with strict aseptic and antiseptic precautions, mid-clavicular point, external jugular vein, and subclavian artery pulsation were identified about 2 cm above the mid-clavicular point, just lateral to subclavian artery's pulsation. A 22 gauge 1.5-inch hypodermic needle attached with 2 ml saline-filled syringe was introduced and directed caudal and medially until paresthesia
motor response was elicited or the first tip was encountered. After brachial plexus was located, the drug was injected, and before every incremental dose, negative aspiration for blood was performed to avoid any intravascular placement, and injection would be stopped immediately if early signs of toxicity appeared. According to the drug administered, the patients were randomly allocated to two groups. Group RC received ropivacaine 0.5% 30 cc and clonidine 1 microgram per kg. Group RD received ropivacaine 0.5% 30 cc and dexmedetomidine 1 microgram per kg. During the conduct of block and thereafter, the patients were observed diligently for any complication of the block and for the toxicity of drug injected. Next slide. Here we observed sensory block. Onset of sensory block was assessed every 2 minutes and graded as grade 0 if no loss of sensation, grade 1 as analgesia, patient feels touch but no pain and pinprick, grade 2 is complete anesthesia, patient even not feel the touch, a sensation or pinprick. Then motor block by asking the patient to elevate the arm while keeping elbow straight and at the hand by grip strength, which were graded as followed. Grade 0, no weakness, grade 1 paralysis, decreased movement with inability to perform activities against resistance, and grade 2 paralysis. Next slide. And then hemodynamic parameters, intraoperative pulse, blood pressure, respiratory rate, SpO2 were recorded. Intraoperative complications like bradycardia, hypotension, nausea, vomiting, pruritus, etc. if present was recorded. Postoperative analgesia, intensity of postoperative pain was evaluated using visual analog score with grade 0 to 10. Pain score were noted postoperatively at 30 minutes, 60 minutes, and then 2 hourly interval till 18 hours and at 24 hours. Analgesia was considered satisfactory if the score was 3 or less. If it was more than 4, then it was considered unsatisfactory and rescue analgesia was administered. Next slide. Here, the pie chart shows the type of surgery in both groups, and they were comparable and there was no clinically significant difference. Then the graph shows the hemodynamic parameters, and it also suggests there were no clinically significant difference. Next slide.
40 seconds left.
Statistical analysis. Here the graph shows mean onset time of sensory and motor block in both groups. There were no clinically significant difference in the both groups for mean onset of time. Next slide. The graph shows mean duration of sensory and motor block in both groups. Here it shows there is prolonged duration of sensory and motor block in RD group. Next slide. Graph 3 suggests postoperative VAS score. Graph 4 suggests mean duration of postoperative analgesia, which suggests that group RD has more prolonged duration of postoperative analgesia. Next slide.
Time up.
Conclude. Here we conclude that dexmedetomidine is more. Dexmedetomidine prolongs the duration of sensory block and motor block and enhance the quality of block as compared to clonidine, and it is better adjuvant than clonidine.
What is the difference between clonidine and dexmedetomidine?
Ma'am, dexmedetomidine is more selective alpha-2 receptor agonist. Clonidine is a general alpha-2 receptor agonist. It has less sedatory, more sedation than, and dexmedetomidine produces more sedation without doing respiratory depression.
Okay.
Next, we have Dr. Manisha Sharma. Are you ready?
Hello? Hello?
Hello.
Hello?
Yes, ma'am, I'm ready.
Hello? Manisha?
Yes, ma'am. Hello.
Hello?
Hello.
Wait for a while. I just let you know.
Okay, ma'am.
Hello? Hello?
Yes, ma'am.
Yes, ma'am. Hello.
Hello?
Yes, ma'am. Can we go
Yes,
ahead?
you can start.
Everyone, our topic for today is comparative study of thiopentone versus propofol for anesthesia and electroconvulsive therapy. ECT, as we all know, known as electroshock, is a psychiatric treatment. Next slide, please. In which seizures are electrically induced in an anesthetized patient for therapeutic effect. The use of ECT is to provoke a generalized epileptic seizure, and it is important in the treatment of severe and medication-resistant depression, mania, and schizophrenia patients. ECT is usually performed 3 times a week for 6 to 12 treatments, and then maintenance therapy can be performed progressively. Next slide, please. The generalized epileptic seizure, it causes also physiological responses, which can be acute cardiovascular responses, which results in an increased cerebral blood flow and intracranial pressure. The maximal blood flow velocity increases approximately 133% above the baseline. It's the next slide. Before that, the hemodynamic responses to ECT can produce, second slide. The hemodynamic response to ECT can produce myocardial ischemia and even infarction, transient neurological ischemic deficits, and intracerebral hemorrhages and cortical blindnesses. Can you please go to the second slide, please?
Yes, 1 minute.
Yeah. The next. Yeah. So I was talking about when the ECT produces a generalized epileptic seizure, it causes cardiovascular responses and it increases the cerebral blood flow and intracranial pressure. And the blood flow velocity also increases by 133% above the baseline value. It also produces hemodynamic responses like myocardial ischemia and even infarction can happen, transient neurological ischemic deficits, intracerebral hemorrhages, and cortical blindness. Next slide, please. The typical cardiovascular response is due to the release of catecholamines. Can you please go to the next slide? Which causes initial parasympathetic, the slide before that, which starts with the typical cardiovascular response.
Really sorry, 1 minute.
That's yes.
Is this okay?
Yes. The typical cardiovascular response, which is due to the release of catecholamines, it causes an initial parasympathetic induced bradycardia, which lasts for 10 to 15 seconds, and it is followed by immediately a sympathetic response, which is prominent, and it results in transient tachycardia and hypertension, which lasts for 5 minutes or longer. And the systolic blood pressure is also increased transiently 30 to 40%, and the heart rate also increased by 20% or more. Hence, acute hemodynamic responses are seen in ECT, which we can conclude. The next slide, please. The other complications, which we already know, are fracture dislocations, muscle aches, nausea, headache, and emergent agitation and sudden death. Aim of my study is to compare the efficacy of anesthetic agents and ECT, comparison of both on hemodynamics, convulsion time, recovery of patients after the ECT. Next slide, please. The inclusion criteria is we included all the patients suiting ASA grade 1 and 2, and also the patients having indication for ECT, that is patients with depression, schizophrenia, bipolar mood disorder, etc. Exclusion criteria would be patient refusal for consent, ASA grade 3 or above, and patient having absolute contraindications for the drugs in my study, that is thiopentone or propofol. Methodology: a total of 10 patients were selected, out of which they were given 6 ECTs. Each of them were given 6 ECTs and 3 per week. And in those 3 per week ECTs, 3 were with thiopentone and 3 were with propofol. Both the drugs were used in the same patients so that the response of the drug can be assessed without patient and disease variance. Detailed anesthetic and psychiatric assessment of the patients was done before the procedure, and the patient was asked to be done by mouth, and a written informed consent was taken. All the equipments for cardiopulmonary resuscitation were available. During ECT, non-invasive monitors were used to record the heart rate and the blood pressure and the oxygen saturation. For smooth anesthesia management of the ECT, the patients were pre-medicated with parasympathetic mimetic to prevent the vasovagal reflex and also to decrease the oral secretions. So the patients were pre-medicated with injection atropine, 10 microgram per kg, to avoid unfavorable parasympathetic reflex. And they were induced with a hypnotic dose of the IV anesthetic agent, followed by the skeletal muscle relaxant. Here, the IV anesthetic agent we used were in the three ECTs were injection thiopentone 1.5 to 2.5 mg per kg, or we also used in the other three ECTs in the same patient were injection propofol 0.8 mg per kg. We were followed by injection succinylcholine, which is the skeletal muscle relaxant, intravenously. Ventilation was assisted with a face mask and with a Megel circuit, and the patient was pre-oxygenated with 100% oxygen. Next slide, please. Bite block was put before the application of electrical stimulus to minimize the risk of lacerating the tongue, and hemodynamic parameters convulsion time were noted. The patient was given 100% oxygen after the convulsion, and during the procedure, awareness was assessed by PRST score. Recovery is observed in the form of gain of reflexes, regain of reflexes, response to pain, and the patient following verbal command. The patient was shifted in the post-procedural room when the patient was following verbal command. Next slide, please. The convulsion time and recovery of anesthesia we saw were the convulsion time was for thiopentone and propofol was noted, and propofol showed that propofol had more hemodynamic stability and rapid recovery compared to thiopentone, but thiopentone had more convulsion time compared to propofol. In the propofol group, the convulsion time was less because it had more anticonvulsive effect than thiopentone. Next, talking about the hemodynamic changes in the both groups, changes in heart rate, and in the next slide we can see the changes in systolic and diastolic blood pressure. Both shows that propofol has more hemodynamic stability and rapid recovery compared to that of thiopentone. This was during ECT. We studied heart rate, systolic blood pressure, and diastolic blood pressure. In discussion, we can see that ECT is a simple procedure and it is extremely safe. But unfortunately, the relapse rate during this 6 to 12-month period of the patients exceeds 50% unless the patient receives a maintenance ECT or a combined pharmacotherapy. So for ECT, the essential elements for anesthesia include rapid loss of consciousness, effective attenuation of the hyperdynamic response due to the electrical stimulus, avoidance of gross movements, minimal interference with the seizure activity, prompt recovery of spontaneous ventilation and consciousness, and no interference with the antipsychotic drugs.
I'm up.
I'd just like to conclude that thiopentone is safe, cost-effective, easily available, and proved agent for induction of anesthesia and ECT. Propofol is a good alternative in patients who are high risk, such as patients with myocardial insufficiency, fixed cardiac output, hypertension, and acute intermittent porphyria, where the thiopentone is contraindicated relatively.
What was the aim of your study?
The aim of our study is to compare the efficacy of propofol and thiopentone in ECT and the convulsion time and hemodynamics and recovery of the patient.
How did you calculate the data?
With the help of t-test.
Okay.
Next, we have Dr. Nautam Kumar Pranami.
Yes, ma'am. Good evening, ma'am.
Good evening.
I am Dr. Nautam Pranami, third year anesthesia resident, IKDRC BJ Medical College. My study regarding the comparative study regarding the effect of dexmedetomidine and propofol on hemodynamic response during tracheal extubation among the hypertensive patients. Next slide, please. Introduction is airway management is a basic aspect of the anesthesiologist, include the ventilation, laryngoscopy, intubation, and extubation. Extubation give laser importance. Slide.
1 minute.
Extubation give laser importance. Then of the intubation risk involved in the regarding to the hemodynamic stability. Often the extubation is associated with tachycardia and hypertension, may produce a myocardial ischemia and infarction in susceptible patient. During tracheal extubation, stimulus which affect the hemodynamic changes are multifactorial, like light plane of anesthesia, pain, emergence of anesthesia, and tracheobronchial irritation, leading to reflex sympathetic discharge. Next. Dexmedetomidine can be used to attenuate the extubation response, as it is sedative, sympathetic, anxiolytic, and analgesic without respiratory depression, and propofol decrease the systolic and diastolic blood pressure by 20 to 30% with minimal change in the heart rate. It can also be used to attenuate the pressure response. Next. Aim is to compare the effect of dexmedetomidine and propofol on the hemodynamic response during extubation among the hypertensive patient, and objective to compare hemodynamic changes, quality of extubation, and post-operative sedation. Next. Material method, it's a prospective randomized control study. After obtaining the consent, age group between the 18 to 65 years, ASA grade 1 and 2 and 3, selected randomly for the different surgery under general anesthesia. Baseline heart rate, systolic blood pressure, diastolic blood pressure, mean arterial pressure, and SpO2 not rate. Then patient given a balanced general anesthesia, and after intubation, again vital recorded, and at the beginning of skin closure, volatile anesthetic discontinued. Our inclusion criteria is age between 18 to 65 years, ASA grade 2 and 3, weight 30 to 80 kg, and surgery under general anesthesia. Exclusion criteria is age below the 18, above the 65 years, history of allergy to dexmed and the propofol, history of psychiatric disease, pregnancy, and patient not giving consent. Next. Group D was given injection dexmedetomidine 0.5 microgram, infusion 10 minutes IV slowly before the extubation, and group P is giving propofol 0.5 milligram per kilogram IV 2 minutes before the extubation, and vitals recorded just before the giving just before the extubation, 1 minute, 3 minutes, 5 minutes, 10 minutes, and 50 minutes after the extubation, and quality of extubation evaluated by the 5-point extubation quality score, and the post-operative sedation evaluated by the 6-point Ramsey scale. About the extubation quality score, for 1 is a no cuffing, 2 is minimal, 3 is a moderate cuffing, 4 for severe cuffing, and 5 is uncomfortable like laryngospasm. And the Ramsey score is 1 for anxious and restlessness, 2 for conscious oriented, 3 for drowsy but respond to command, 4 for asleep and brisk response to light globular tap and loud auditory stimulus, 5 for asleep with sluggish response to light globular tap, and 6 for asleep and unavailable. Next. Statistical analysis was performed on EpiInfo version 7.1, and baseline variable were compared between the two groups using student test for independent variable, and nominal data were calculated using the chi-square test. This is a graph showing a gender distribution. There is no significant difference. Next. Next chart graph showing a comparison of heart rate. It's a statistically significant decrease the heart rate after giving a dexmedetomidine than the propofol. Next. Systolic blood pressure comparison. So markedly significantly decrease the systolic blood pressure in dexmedetomidine than the propofol. Also, a diastolic blood pressure see a significant difference decrease in the diastolic blood pressure in the dexmedetomidine than the propofol, and also the mean arterial blood pressure is decreased in the dexmedetomidine group than the propofol group. Exhibition score is better in group dexmedetomidine than the propofol, suggests this chart. And the last chart of the Ramsey sedation score, the patient of group P were more drowsy than group D, but responding to verbal command. Next, discussion is to tracheal extubation is defined as the cause of temporary but critical heart rate and blood pressure elevation in 10 to 30% of patients. Is a transitory and variable during and after the tracheal extubation. And Kodiak et al. Shows in coronary arterial disease patient there decrease in ejection fraction 40 to 45 to 55% after extubation. And these changes are more profound seen in cardiovascular disease, cerebrovascular disease, and renal disease. This, if not controlled, can lead to a cerebral hemorrhage, myocardial ischemia, and pulmonary edema. So it should be controlled by anesthesiologist. Next. Dexmedetomidine is alpha-2 agonist, which is sedative, anxiolytic, analgesic, symptolytic without respiratory depression, and it follows the heart rate and blood pressure associated with decrease in SVR by activating a presynaptic alpha-2 adrenergic receptor. Propofol is a non-opioid, non-barbiturate sedative hypnotic agent with rapid onset and short duration of action. Propofol consists of GABA receptor activity and mechanism of action by hyperpolarization, and it reduces the BP by blood pressure by SVR and the preload and cardiac contractility. Next slide. Comparison of heart rate. Group D is more reduced than the group P because of subhypnotic dose of propofol, which is not sufficient to counter catecholamine secretion during the exhibition. In systolic blood pressure, also group D is good because of decrease in SVR and Stockholm index. Next. Conclusion was to dexmedetomidine is better in controlling heart rate, systolic blood pressure, and the quality of exhibition than the propofol. Dexmedetomidine is an effective and safe drug to provide stable hemodynamics and protect against the stress response to exhibition. These are my references. Thank you.
What are the criteria of extubation?
Ma'am, normally criteria patient should be awake, alert, and vitally stable. Three protective reflexes are the gag reflex, swallowing reflex, and cough reflex, and adequate neuromuscular reversal.
Okay.
Thank you.
Next, we have Dr. Parul Goel.
Yes. Shall I start?
Yes, you may.
Good afternoon, ma'am. My topic for today is evaluation and analysis effect of caudal dexamethasone with bupivacaine in pediatric genitourinary surgery. Next slide, please. ISAP, that is International Association for Study of Pain, defined pain in unpleasant emotional and sensory experience associated with actual or potential tissue damage. Pain is a protective mechanism designed to alert the body to injurious stimuli. Caudal epidural lock is one of the most common regional technique in pediatric anesthesia. It is also safe and reliable technique, easy to perform, and very effective in children, especially in inframedical surgeries when combined with general anesthesia. It allows rapid recovery with good post-operative analgesia. Prolongation of analgesia can be achieved by addition of various adjuvants such as opioids, ketamine, neostigmine, and midazolam. Bupivacaine acts by mainly blockage of voltage-gated sodium channels in axonal membrane, which also causes presynaptic inhibition of calcium channel. Corticosteroids have anti-inflammatory action, which have been used via epidural, intracathal, caudal, perineal routes for prolonging post-op analgesia. Dexamethasone, which is a corticosteroid used mainly in perioperative period to reduce nausea and vomiting. It also has analgesic effects. Next slide. It is local anesthetic effect by direct membrane action. It is also another effect which acts on spinal cord. The transcription factor, nuclear factor, that is NFKB, is expressed to nervous system, which has a role in pathological pain pathway. Dexamethasone regulates NFKB. Epidural injection of corticosteroids have been reported to inhibit the development of hyperalgesia. Next slide. My aims and objectives are: my study is randomized prospective interventional study of caudal dexamethasone as an adjuvant to bupivacaine in pediatric patients. The aims are intraoperative hemodynamic parameters, intraoperative concentration of inhalation agents, peri and postoperative complications, comparison of duration of analgesia, to assess the requirements of supplemental analgesia, if any, to assess the side effects, if any. Next slide. Materials and method. After obtaining approval from Institutional Ethical Committee, written informed consent was taken. Total 80 pediatric patients were allocated in two groups, 40 each. The first group was BD, which had 1 ml per kg, 0.25% bupivacaine with 0.1 mg per kg dexamethasone, whereas B group had 1 ml per kg, 0.25% bupivacaine. Inclusion criteria were age group 6 months to 6 years, ASA grade 1 2, gender both, elective genitourinary surgeries, and duration of surgery not more than 2 hours. Exclusion criteria: ASA grade 3, 4, 5, emergency surgeries, local infection of caudal areas, history of allergic reactions to local anesthetics, bleeding, diastasis, and pre-existing neurological spinal disease, mental retardation, neuromuscular disorders. Next slide, please. Previous slide. In pre-operative assessment, patient's birth history, general examination, system examination, allergy, operative history was taken. HB, complete CBC, RBS, blood urea creat, LFT, 2D echo, X-ray was done before operation. Pediatric reference was done in some patients. Preparation in OT, baseline vitals such as ECG, pulse, NIBP, SPO temperature were recorded in all the patients. IV line was secured with 24-22 gauge IV cannula and IV fluids were started. Patients were pre-medicated with injection glycopyrrolate 4 microgram per kg, injection ondansetron 0.15 mg per kg. Pre-oxygenation was done with 100% oxygen at 5 to 7 liter per minute for 3 to 5 minutes via Jackson recircuit. And induction was done using inhalation method 50% oxygen, 50% nitrous oxide, and 2 to 7% sevoflurane. Airway was secured with IGL and ET tube after effect of IV succinylcholine 2 mg per kg. Caudal was performed with 22 gauge epidural needle under complete aseptic precaution. Child was put in left lateral position with the both hips and knee flexed. Sacral hiatus and caudal space was identified by the pop-up technique when penetrating the sacrococcygeal ligament. Sudden loss of resistance and after complete placement of needle in caudal space after negative aspiration of CSF and blood, 1 ml per kg of blinded study solution is injected. Patient were repositioned spine. Patient were maintained with 50% O2, N2O and sevoflurane 2 to 4%. Intraoperative, no analgesia was given. Patient hemodynamics such as heart rate, NIBP, SpO2, EtCO2 temperature were recorded. Recorded at the time of pre-medication induction laryngoscopy after caudal, then every 5 minutes and 30 minutes, after intubation, then every 15 minutes 90 minutes. Intraoperative IV fluid was given according to the requirement of surgery. If the increase in heart rate and systolic blood pressure within 15-20 minutes skin injection was considered, then it is a failure of caudal anesthesia. Extubation was done. Next slide. Postoperative pain was evaluated by FLAC score, which is face, leg, activity, cry, and consolidability tool at 30 minutes interval for up to first 2 hours, then 1 hour interval for next 3 hours, then after every 2 hour interval. If FLAC score was more than 4, then rescue analgesia was given. Sedation was assessed by using sedation score, which has 4 grading, 0, 1, 2, 3. 0 is spontaneous eye opening, 1 is eye opening on speech, 2nd is eye opening on shake, 3 is arousable. This is FLAC post-operative pain score. Next slide. Statistical analysis. All the observations were recorded and results will be analyzed statistically. Data will be entered in Microsoft Excel and analyzed using student t-test. Numerical data will be expressed as mean plus minus. SDP value less than 0.05 will be interpreted as clinically significant. Next slide. This is the first graph, that is post-operative pain score, FLAC score. So here you can see one is group BD, other is group B. So in starting, the pain is less in group BD since we have given dexamethasone along with bupivacaine, and the next group is group B, so pain is more in the starting 2 hours, 3 hours, 4 hours, and after 24 hours, the pain is almost equal in both the groups. Next slide. The next slide is post-operative sedation score. In that, it shows that both the groups, the sedation was not there, so it is beneficial that BD and B both are almost equal. Next slide. Mean duration analgesia is better in group BD compared to group B. Next slide. Result. International Association for Study of Pain has defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Regional anesthesia not only provides an extended pain-free period but also reduced stress response to surgery. Caudal block has been found to be excellent and safe technique for providing post-operative analgesia in pediatric population with high success rate. Placing the block before surgical incision provided intraoperative pain relief, reduces the general anesthetic requirement, and achieves earlier recovery of airway reflex. We designed this randomized prospective intervention study to evaluate the analgesic effect of caudal dexamethasone with bupivacaine in pediatric genitourinary surgery. Our drug, which is bupivacaine, is an amide long-acting anesthetic agent. It blocks sodium channels in neural membrane, resulting in voltage-dependent membrane permeability. It also inhibits depolarization and causes reversible loss of sensation. Next slide. My conclusion shows that the study which has done in 80 children, genitourinary surgeries, group BD, which is bupivacaine plus dexamethasone, is better than group B, that is bupivacaine, because in group BD, post-operative analgesia is better and less requirement of doses given, according to FLAC score. Thank you.
What are the complications of caudal epidural in pediatric patients?
Ma'am, first is if caudal is given in skin subcu, that it will not go there, so it can cause swelling, hematoma, or it can cause nerve injury.
Anything else?
Then bleeding can be happen, and local infection can happen at the injection site, and possibly a headache if dura is punctured.
Okay.
Thank you, ma'am.
Next, we have Dr. Rashmita Jasolia.
Hello, am I audible?
Yes.
Hello.
Hello, yes.
Hello, this is Dr. Rashmita Jasolia, second year resident doctor from BJMC. Good afternoon, everybody. My topic is efficacy of low dose IV dexmed for prolongation of analgesia and supraclavicular block. As we all know, it has gained recent popularity in recent year because people having comorbidity are not usually beneficial of giving general anesthesia.
You are not audible.
This block is most commonly performed in peripheral neural block for upper extremity. There are various approaches for but supraclavicular block is most easiest and safest to perform as such. Next slide, please. This block was introduced in 1911 by Klunkruff. Anesthesia this gives anesthesia to entire upper extremity. Supraclavicular approach blocks brachial plexus at the level of distal trunk. It can be performed with patient's arm in any position. It is excellent anesthesia below elbow, forearm, hand, and surgery. Well, axillary approach, it is less beneficial as there are more chances of patchy results. It gives patchy blocks, and it is as it is slow success. And tourniquet pain during prolonged surgery is also a disadvantage. Next slide, please. An interscalene approach, although as it is shown that there are more chance of nerve injury and intraarterial ingestion in this approach, and more chance of Horner syndrome. And this image is showing various approach of interscalene, supraclavicular, and infraclavicular block. We can use various sedative like morphine, clonidine for faster onset and prolonged duration of blockage. Next slide, please. Dexamethasone is fluorinated derivative of prednisolone, which has anti-inflammatory property. Analgesic mechanism of dexamethasone is still yet not unclear, but it blocks the cyclooxygen and lipoxygenase pathway production, and basically blocks the peripheral lipophospholipase. Bradykinin, which is really reduced by which reinforce pain to the inflamed tissue. Local inflammation blocking of the transmission of the nociceptive unmyelinated C fiber and supporting ectopic neuronal discharge. My aim of study is today. Next slide, please. Onset of sensory motor blockage, peak effect of blockage, duration of analgesia, and duration of sensory and motor blockage, and in last complication if any. Next slide, please. Material and method. So after getting all formalities done, I have chosen 15 patients. Like according to inclusion and exclusion criteria, I have included ASA 1-2 grade group healthy group 18 to 16 year of age and person who need emergency surgery. In exclusion, I have excluded cardiac, renal, hepatic failure, people who have comorbidity, most important people who have refusal for surgery. I have excluded such kind of patient. So basically, I have divided group C and D. In group D, I give bupivacaine 0.5% 15 ml and lignoadrenaline along with it my study drug IV dexmed 8 mg, which is 2 ml. In group C, I give other than dexmed. Next slide, please. Next slide, please. Hello. In procedure, first after securing IV line attached in all the monitors, group C and group D people were given drugs according to previous group divided. And mainly block was given by USD guided, either USD guided or PNS guided. And supraclavicular approach needle was directed after palpating subclavian artery postero-superiorly. We can use both PNS guided and USD both. Next slide, please. In PNS guided, after persistent movement at 0.5 milliampere, the drug was given. And if any complication during perioperative period, if noticed, it was corrected. And if unsatisfactory effect we note, we can give general anesthesia. Next slide, please. The main parameter as I already said, I observed sensory motor blockage duration, peak effect, duration, and if any complication occur. And the sensory and motor block, according to modified Brome scale, was divided as shown in the table. Next slide, please. This is showing VAS score, which is from 0 to 10. 10 is unbearable pain, worse pain, and 0 is having no pain. In my study, if score is more than 4, it means if pain is more, if it is unsatisfactory, then general anesthesia was given to the patient. And both in both group, the duration of analgesia, time of onset, sensory block, duration of motor block, everything was recorded. Next slide, please. This is graph 1 showing demographic data, like what age, sex, age, weight, sex we have chosen, and group C and D. This is p-value showing significant difference, as here it is clearly shown that in group D p-value is greater than 0.005. Next slide, please. This is graph 2. In this light blue color is group D and dark blue color is group C. So in light blue color, it is clearly shown that onset and motor blockage is earlier than group C, in which group the drug dexmed was not used. Next slide, please. This is again table 3 and table 4 for duration of surgery and procedure time. It is clearly shown that it is in group C. It lasted for long time because it is in group D, drug was used. Same as in table 4. Next slide, please. This is graph and table for duration of sensory motor blockage and analgesia. As it is clearly shown that light blue color in group D, it is clearly showed that after using additive dexamethasone, the effect is lasted for longer time. Next slide, please. This is VAS score. This VAS score is showing clearly that less VAS score is suggestive of less pain. So the light group color, group D, where we have uses this dexamethasone, VAS score is less. And even after duration 20 till 20 hours, the duration is less. It is clearly seen from data and table also. Next slide, please.
30 seconds left.
This variable of heart rate, basically hemodynamic change in both the group. This is almost same in the both the group. Next slide, please. Its regional anesthesia is increasing popularity in recent years. This block is excellent alternative for hemodynamic compromised patient, like who has systemic comorbidity. Steroid along with local anesthetic is effective and significantly prolong the duration of analgesia, as well as producing earlier onset of action. This dexamethasone is 9-alpha derivative of synthetic glucocorticoid, which is highly potent anti-inflammatory potent, like 25 to 30 times more potent than hydrocortisone.
Time up.
Next slide, please. As this data is showing that in group D, we have used the drug. So mean onset of duration and everything is more than group C, where we have not used the drug. Next slide, please. Next slide, please.
What is the difference between
previous slide, please?
Sorry, time out.
Okay.
Hello.
Hello.
Yes. What are the complications of supraclavicular brachial plexus block?
Hello.
What are the complications of supraclavicular block?
Yes, ma'am. Complication is if local site infection is there, then high acidic pH, then it cannot be given. It can give in vascular, like it can be in subclavian artery. So systemic toxicity of local anesthetic can also be there.
Any other
local site hematoma? Local site hematoma can occur if vascular injury is there by mistake.
Anything else?
Pneumothorax can also occur if needle might injure the apex of pleura.
Okay.
Next, we have Dr. Ritisha.
Hello.
Are you ready?
Yeah, I'm ready. Am I audible?
Yes.
Okay. Good evening, everyone. Myself, Dr. Ritisha from Sumandip Vidyapith, third year resident doctor of anesthesiology. My topic is
1 minute.
okay. Okay. Can I start?
Yes, you can start.
Okay. My topic is an observational study on the effect of the dexmedetomidine on a hemodynamic and airway responses during extubation of the trachea following the major surgery under general anesthesia. Next slide, please. Tracheal extubation is the discontinuation of an artificial airway provided when the indications for its placement, like the airway obstruction, protection of the airways, suctioning, ventilatory failure, and the hypoxemia no longer persist. Appropriate use of the sedative, hypnotic, and analgesic agent is an important aspect of balanced anesthetic technique, providing patient comfort and safety during anesthesia. Anesthetic maneuvers like the direct laryngoscopy, tracheal intubation, and the extubation involve the severe sympathetic stimulation as well as the increase the plasma catecholamine levels, which cause the tachycardia, increase the myocardial contractility, and the systemic vascular resistance. Next, please. An appropriate agent or the combination is helpful to alleviate the noxious stimuli, distress, and the anxiety, which may minimize the risk of the adverse side effect during the extubation. But for a perfect extubation, there should be no movement, no straining, no coughing, no breath holding, or no laryngospasm. Various agents like the lignocaine, opioid, esmolol, calcium channel blocker, magnesium sulfate, and the propofol have been shown to be stop the adverse responses, but they all have the limitation and the side effects. Dexmedetomidine is a potent and highly selective alpha-2 adrenoreceptor agonist with a sympathetolytic, sedative, amnestic, and analgesic property. Dexmedetomidine depresses the gag reflex and improves the tracheal tolerance when compared with the other sedatives. We designed this observational comparative study to determine the effect of dexmedetomidine IV infusion given before the extubation for the effective attenuation of the hemodynamic and airway responses to the tracheal extubation. Aim of my study is to evaluate the effect of the dexmedetomidine on a hemodynamic and airway response during the extubation. Objective to observe and compare the effect of the dexmedetomidine with a normal saline on a hemodynamic, heart rate, and blood pressure responses during the extubation. To evaluate and compare the airway responses based on the frequency of the cupping immediately after the extubation using 5-point rating scale, which is extubation quality score, to observe for any complications. Next, please. Material and methodology. After the ethical committee approval and a written informed consent was taken from the patient, pre-anesthetic checkup was done and a detailed history and a clinical examination, physical examination was done and a routine investigation was done. We divide the patient into two groups, Group A and Group B. Group A patient received injection dexmedetomidine 0.5 microgram per kg IV infusion in 100 ml NS over 15 minutes before the extubation, while in Group B, 100 ml NS IV infusion over 15 minutes before the extubation given. For inclusion criteria, patient's willingness to give the informed consent, either gender, age group of the 18 to 65 years, elective major surgery of more than 1 hour duration, ASA 1 and 2 patient, Malampatti classification, Malampatti airway class 1 and 2. For extubation criteria, usual ASA 3 and 4, BMI more than 35, with bradycardia or any hypotension on medication that affect the heart rate and blood pressure, pregnant and lactating mothers, Malampatti airway class 3 and 4, and history of the obstructive sleep apnea. Next, please. We advise patient the NBM for the 6 hours. Then after shipping the patient in the OT, multipara monitor was attached and the baseline vitals are noted. IV line was secured. Patient was pre-medicated with the injection glycopyrrolate 0.004 mg per kg IV, injection ondansetron 0.1 mg per kg, injection midazolam 0.05 mg per kg, injection tramadol 1 to 2 mg per kg IV. All the patients were pre-oxygenated for the 5 minutes with the 100% oxygen. Induction was done with the injection propofol 2 to 3 mg per kg IV and injection succinylcholine 1 to 2 mg per kg. Intubation was done by the direct laryngoscopy using the appropriate sized cupped endotracheal tube. Patient was attached to the breathing circuit of the anesthesia machine and checking the bilateral air entry, the tube was fixed. Maintenance with the isoflurane and with the O2 and N2O 50-50%. Injection atracurium with a loading dose of 0.5 mg per kg and the maintenance dose is 0.1 mg per kg as needed till the end of the surgery. After 15 minutes, about 15 minutes before the estimated time of the end of the surgery, patient received the study drug according to the randomization. Heart rate, systolic BP, diastolic BP were recorded at the baseline at the start of the infusion of the drug, 3 minutes after, 5 minutes after the infusion, 10 minutes after infusion, and 15 minutes after the infusion of the drug. Reversal was done with the injection glycopyrrolate 0.008 mg per kg IV and the injection neostigmine 0.05 mg per kg IV. When the patient's spontaneous respiration was considered as adequate and the patient were able to obey the verbal commands, trachea was extubated after suctioning of the throat. Heart rate, systolic BP, diastolic BP are recorded at the time of the extubation, 3 minutes after extubation, 5 minutes after extubation, and 10 minutes after extubation. Next slide, please. Occurrence of the event like the laryngospasm, bronchospasm, fall in a saturation, bradycardia, or the hypotension were recorded. Airway responses was evaluated based on the frequency of the coughing immediately after the extubation using 5-point rating scale, which is the extubation quality score. Number 1, there is no coughing. 2, smooth extubation with a minimal coughing 1 or 2 times. 3, moderate coughing. 4, severe coughing. And 5, poor extubation and very uncomfortable. There is a laryngospasm or coughing and more than 10 times. Next, please. Observation and result. The distribution of the patient with respect to the age and weight was statistically not significant in both the groups. Table shows the mean heart rate at the different time interval in both the group. Next, please. From the graph, we can see that the mean heart rate at the time of the extubation in a group A and group B, there was highly significant differences in both the group. Next slide, please. Table shows the change in the mean systolic blood pressure at the different time interval in both the groups. Next, please. From the graph, we can see that the highly significant differences in systolic BP observed between the group A and group B at the time of the extubation. Next, please. Graph shows the mean diastolic BP at the different time of the intervals. Next, please. From the graph, we can say that in a group A and group B, there is a highly significant differences was observed in a group A and group B at the time of the extubation and thereafter.
30 seconds left.
Okay, extubation quality score is given. Next, please. We observed a significant difference in the quality of the extubation between the two groups. In group A, 21% patients extubated smoothly with a minimal coughing, wherein only 2 patients were extubated smoothly with the extubation quality score 2 in a group B. Moderate coughing with the extubation quality score 3. Discussion. Recovering from the anesthesia often result rise in a catecholamine concentration after anesthetic withdrawal, which is further aggravated by the laryngeal stimulation done at the time of the tracheal extubation. Complication at the extubation include the tachycardia, hypertension, dysarrhythmia, coughing, laryngospasm, bronchospasm, impaired laryngeal function, pulmonary aspiration, and hypotension. Dexmedetomidine activates the receptor in the medullary center, decreasing the norepinephrine turnover and reduce the central sympathetic outflow, result in alteration in the sympathetic function and decrease the heart rate. Next, please. Conclusion. Thus, we can conclude that the use of the injection dexmedetomidine 0.5 microgram per kg IV infusion in 100 ml NS before 15 minutes of the extubation can successfully attenuate the hemodynamic response. It also enables the smooth extubation of the trachea without respiratory depression. Thank you.
What was the method of calculation of data in your study?
Ma'am, student t-test.
Okay. And what are the criteria of extubation?
Ma'am, neck holding, obey verbal commands, gag reflex, eye opening.
Okay. Okay.
We have Dr. Saida Majpurwala. Are you ready?
Yes, I'm ready. I'm audible?
Yes.
Good evening, everyone. Good evening, ma'am. Today, my study is comparison of preoperative versus postoperative bilateral rectal sheath block for effective perioperative analgesia in patient undergoing emergency midline incision peptic perforation repair. Next, please. Next slide, please.
You are not audible.
Hello, am I audible?
Okay.
Can you see the slides? It's the introduction slide.
Hello, am I audible now?
Yes.
You can go ahead.
Hello.
Hello.
Am I audible?
Yes, you are audible.
Hello.
Hello. Go ahead.
We can take Dr. Saida's presentation at the end. We can proceed with the next one. Will that be okay?
Hello, am I audible?
Yes, you are audible.
Sorry. So my introduction, preemptive analgesia. It is a treatment that is initiated before the surgical procedure in order to reduce the sensitization of peripheral and central pain pathways evoked by tissue damage. The available methods are we can use parenteral or oral NSAID, sublingual or intravenous IV opioids, parenteral NMDA receptor antagonist, local anesthetic as neuroaxial administration or peripheral blocks, wound infiltration or intraperitoneal instillation, and also systemic antiepileptics like GABA and all are also useful. Significant pain experienced by the patient after any upper abdominal surgery is derived from the abdominal wall incision, which has a considerable negative effect on the patient's immunity. Next. In our study, we have used rectal sheath block as a preemptive analgesia. Slide before this. Can I get the third slide?
You are not audible.
Can I get the third slide? Rectal sheath block. Rectal sheath block was first described by Schleich in 1899 to provide perioperative relaxation of anti-abdominal wall from intra-abdominal surgery. Rectal sheath block conducted with general anesthesia can reduce opioid use and post-operative pain. Local anesthetic drug injected via RSB block the ventral rami of the 7th to 12th intercostal nerve, thus anesthetizing the middle portion of the anterior abdominal wall from xiphoid process to the symphysis pubis in adults and providing an analgesic effect in the area. In the present study, we have hypothesized that preoperative RSB may decrease the intraoperative analgesic requirement and also lessen the deleterious impact of the intraoperative and early postoperative noxious input, thus providing adequate preemptive analgesia. Next, please. Aim of my study is to evaluate the efficacy of preoperative versus postoperative bilateral rectal sheath block for better perioperative analgesia. Objectives are intraoperative analgesic consumption, time to first rescue analgesia, postoperative pain assessment by NRS scale, total and cumulative analgesic requirement over 24 hours postoperatively. Next. A rectal sheath block was given by loss of resistance technique. Under sterile aseptic precaution, a 22-gauge stout beaver needle was inserted at 3 to 5 centimeter above the umbilicus, medial to the lateral border of the rectus abdominis. The anterior rectal sheath was identified by moving the needle from side to side with a back and forth motion while advancing the needle until it was felt to scratch the sheath, posterior sheath. The needle was then advanced until the resistance of the posterior layer of the rectal sheath was felt and the drug was injected after a negative aspiration test. The time for rectal sheath block was noted. Next, please. As we can see in the anatomy, we have to pierce the skin, subcutaneous tissue, anterior rectal sheath, the rectus muscle mass, and until we reach the posterior rectal sheath, and then we inject the drug. Next. Next, please. In our study, we recorded the data according to the demographic data like age, sex, weight of the patient were recorded. Vital parameters were recorded before the study and after induction every 15 minutes after intubation, and at 1 hour, 2 hour, 4, 8, 16, and 24 hour post-operatively. Heart rate, systolic, diastolic, and mean arterial pressure were recorded. Intraoperative analgesic consumption, duration of the surgery, duration of anesthesia, time to first rescue analgesia, NRS score, and total and cumulative analgesic requirement were assessed. Next, please. Data was entered and analyzed using MS Excel and Open API software. Categorical data were presented as frequency and percentage and contains data by mean SD. Mean comparison of analgesic consumption between the two groups was done using student t-test, and differences were considered statistically significant if p-value was less than 0.05. Next, please. As we can see, the rescue analgesic consumption in 24 hours post-operatively. I think you have missed 1 or 2 slides in between. Next. The demographic data is shown in the figure. The patient demographic data like age, weight, preoperative vitals, and were comparable in both the groups 1 and 2. The duration of the surgery and anesthesia were not significantly different between the two groups. Next, please. The intraoperative analgesic requirement, the pre-rectal sheath block group had significantly lower intraoperative fentanyl consumption, that is 177.15 microgram. Then the post-RSB group, that is 339.5 microgram, and the p-value is less than 0.05, which was statistically significant. Compared with the post-RSBS group 2, The pre-rectus sheet block group 1 had no significant changes in the vital signs related to the skin incision. Next, please. The cumulative analgesic requirement, we studied the analgesic requirement at 0, 1, 2, 4, 6, 8, and 16, 24 hours. And as you can see, there was no significant difference between the both groups post-operatively. Next. The graph shows the same data. Next, please. Next, please. Discussion. In our study, we observed that intraoperative analgesic requirement is decreased significantly in the pre-rectus sheet block group as compared to the post-rectus sheet block group. The time to first rescue analgesia, analscope, and post-operative analgesic consumption was similar in both the groups. Our result was in accordance with the study taken by Abdul Salam, who reported excellent perioperative analgesia for upper abdominal surgery using combination of bilateral USG-guided RSV and TAB block. Similar to a study, he had intraoperative analgesic requirement was reduced in the group given the block preoperatively. Next. Heinwon Jong conducted a study on preoperative versus postoperative RSV block for acute postoperative pain relief after left chole, and he reported similar effect of a reduction in intraoperative analgesic requirement, and also they reported a significant decrease in total as well as cumulative postoperative analgesic consumption, which was not in accordance to our study. In our study, the postoperative requirement of analgesia was similar in both the groups. Next, please. We concluded that, can you get the conclusion? We concluded that preoperative rectus sheet block provide good intraoperative analgesia, but there is no significant change in postoperative analgesia, total as well as cumulative, when compared to the postoperative rectus sheet block.
What was the aim of your study, Saida?
My main aim was to differentiate and to study the preemptive analgesia between the preoperative versus postoperative rectus sheet block.
Okay. Next one.
Thank you, ma'am.
Next, we have Dr. Shalini Rathod.
Hello.
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 Yes.
Good evening, ma'am.
Good evening.
Myself, Dr. Shalini Rathod. I'm third-year resident at BJMC IKDRC. I'm presenting a paper with the use of ultrasonography for pre-op airway assessment. Next slide. Introduction. So, airway management is at the core of safe anesthetic practice. Assessment of patients' airway preoperatively commences with a comprehensive history, physical examination using conventional bedside examination technique with the aim of predicting and thereby planning ahead for potential problems in both standard laryngoscopy, intubation, and oxygenation. Ultrasonography can serve as an alternative for upper airway evaluation. Considering the evidences and resources available in the use of sonography for airway assessment, we decide to initiate a study to determine feasibility of imaging airway structures and its clinical usefulness in normal adult patients for predicting difficult intubation. Next slide. So preoperatively, all the routine workup was done. Malam patti grading and other parameters of airway examination was assessed. And prior pre-anesthetic ultrasound scanning, the ultrasound view of the airway of all study patients was assessed by the same anesthesia consultant with a high-frequency linear probe. Position of the patient supine with active maximal head tilt, chin lift, and linear probe with high-frequency transducer was used for this study. Probe was placed in a submandibular area in the midline, and the probe was next slide.
Probe was rotated from cranial to caudal direction, and all the airway structures were visualized. And below are the images which we can see on the ultrasound images. Next slide. Okay, so after visualizing all the structures on the ultrasound, the window which depicted simultaneous visualization of the epiglottis and the posterior most part of the vocal cords with arytenoids was observed, and the following parameters were measured, that is distance from the epiglottis to the vocal cord, then depth of the pre-epiglottic space, and the ratio of pre-epiglottic space to epiglottis to vocal cord distance. Next slide. Okay, so the patients were then taken to the operating room and were administered balanced general anesthesia and intubated with a direct laryngoscopy by a third-year senior resident, and CL grading of the vocal cord was seen and it was noted, and patient was intubated with a PETT 6.5 to 8.5, and maintenance with injection atracurium, isoflurane, and oxygen and air. And at the end of surgery, patients were extubated after reversal of the neuromuscular blockage. Next slide. Statistical analysis. All data was analyzed by SPSS 20.0, and a p-value of less than 0.05 was considered statistically significant. The table here shows the demographic data. Next slide. This table shows the sensitivity of all the structures that are seen from hyoid bone to esophagus on the ultrasonography. Next slide. These are the data showing the parameters that we have measured, that is pre-epiglottic space to epiglottis distance, pre-epiglottic space, epiglottis to vocal cord distance, and pre-epiglottic space to epiglottis to vocal cord distance ratio. Next slide. As the comment from the above data, we can say that as the CL grade increases, the pre-epiglottic space measured and the ratio between the pre-epiglottic space and epiglottis to vocal cord distance increases, whereas the epiglottis to vocal cord distance decreases. So we can say that pre-epiglottic space has a strong positive correlation with the CL grade. Epiglottis to vocal cord distance has a negative correlation with the CL grade, whereas pre-epiglottic space to epiglottis to vocal cord distance ratio has the strongest positive correlation with the CL grade. Next slide. Next slide. Okay, so a wide variety of scoring systems based on the multifactorial analysis have been devised for preoperative airway assessment and prediction of difficult airway. One such example is the Lammen law for difficult intubation. Next slide. In our study, we were able to identify all the relevant structures in most of our patients using the transverse orientation of a linear probe. We could successfully identify the epiglottis, hyoid bone, base of the tongue, cricoid cartilage, tracheal rings, and esophagus in all the cases. Some amount of technical difficulty was encountered in a thin male patients due to the prominence of the Adam's apple, giving a success rate of 86% for adequately viewing the thyroid cartilage and a 76% for vocal cords. Next slide. So widespread awareness, better technological advancement, portability and availability of the ultrasound in most critical areas can facilitate the upper airway ultrasound to become the potential first-line non-invasive airway assessment tool in the future. Next slide. So analyzing the data of the measurement of the pre-epiglottic space, we referred that the greater the distance, the more the tendency of a higher CL grade. Additionally, the lower the value of epiglottis to vocal cord distance correlated with the increasing difficulty in terms of the Cormack-Lehane grading. However, a large pre-epiglottic space with a large epiglottis to vocal cord distance would lead to a normal or a small ratio, which would qualify as an indicator of easy intubation. only indicating a larger force, requiring larger force to lift the large epiglottis as suggested by a large pre-epiglottic space. From this study, we conclude that the ultrasonography of airway is feasible and reliable to delineate different airway structures, thereby enabling it to become a part of routine preoperative airway evaluation. It can be used in conjunction with other clinical predictors to predict difficult intubation more accurately. Next slide.
20 seconds left.
Next. So we used only the transverse view of the linear probe transcutaneously placed to visualize the structures. Different planes like sagittal and parasagittal, different approaches like intraoral, sublingual may perhaps help in better viewing of the different structures. We did not include the obese patients in our study, so more studies are required to see for the usefulness of USG guided airway assessment in obese patients. Next slide.
Time's up.
These are the references. Thank you.
Which are the other different methods of airway assessment?
Ma'am, first of all, there are bedside methods like we can look for external features indicating the difficult intubation, like obesity, facial hair, short neck, then edentulous patient, then other methods like MPG grading, mouth opening, then thyromental distance, hyomental distance can be viewed, and there is one more score. There are certain scores like lemon score.
Yeah, right.
Yes.
Okay.
Thank you.
Next, we have Dr. Shweta Patel. Are you ready? Dr. Shweta Patel. Dr. Shweta Patel, are you there?
Yes, I am audible.
Yeah, okay.
Yes.
Okay. Shall I start? Hello.
Yes.
Oh, okay. Good evening, ma'am. My topic is comparison of anatomical landmark guided two different approaches for IJV cannulation in tertiary care hospital. Next slide. Next slide. It is a vital intervention in critically ill in patients of major elective and emergency surgeries and cardiac surgeries. Mostly right interjugular vein cannulation is used. Indications of IJV cannulations are continuous hemodynamic monitoring, administration of drugs likely to induce phlebitis, to administer vasopressor and volume expanders in hypotensive and hypovolemic patients, edematous patients who have no peripheral veins, extensive burn patient, for total parenteral nutrition, for hemodialysis. Next slide. There are two approaches, anterior and posterior. Mostly anterior approach is used due to easy identification of landmarks, palpation of carotid arteries, but there are disadvantages of carotid artery puncture, hematoma, and pneumothorax. This study how to compare both approaches of IJV cannulation in terms of ease of insertion, time of insertion, number of attempts, ease of threading, number of complications, and outcomes. Next slide. We are divided two groups. Group 1 in which we used anterior approach, and group 2 in which we used posterior approach. Inclusion criteria are ASA grade 1 and 2, all adult patients between age 18 to 65 years. Exclusion criteria are superior vena cava syndrome, infection at site of cannulation, patients with coagulopathy, carotid disease, prior neck contracture, recent cannulation of IJV. In both procedure, anterior and posterior approach, first, after preparation of skin, we use 2% lignocaine, local anesthesia injected. In anterior approach, at 30 degree, we use the needle between two head of apex, mid of two sternocleidomastoid and inferiorly clavicle towards ipsilateral side of nipple. Two tissue pops are felt, paravertebral fascia, and second is vein wall. This is Seldinger technique. In posterior approach, EJV cross posterolateral border of sternocleidomastoid. From there, we lift the muscle and needle 30 degree enter towards the suprasternal notch. Next, parameters observed during procedures are number of attempts to identify vein, time for cannulation, ease of threading, carotid artery puncture, and hematoma. Parameters observed post-procedure pneumothorax, hemothorax, catheter displacement, thrombophlebitis. This is statistical analysis. Data expressed in mean plus standard deviation. This is quantitative analysis was compared with student t-test. P-value less than 0.05 statistically significant and less than 0.001 highly significant. Next slide. This is demographic data to compare both group 1 and group 2 for number of attempts and all. Next slide. Results and complications are counted. Number of attempts are less in posterior approach. In anterior approach, 48% patients cannulated in first attempt, whereas in posterior approach, 84% are cannulated in first attempt. Time to identify vein is also less in posterior approach. It is 0.16 seconds, and it is more in anterior approach. It is 1.12 seconds. Posterior procedure complications are also Post-procedure complications are also less in posterior approach of IJV cannulation. Two cases of posterior approach cannulation done successfully in first attempt, in whom we have tried first anterior approach, which was failed as patient body mass index were borderline and who were obese. So posterior approach is also good in obese patient. The conclusion is posterior approach is more beneficial than anterior approach in terms of ease of insertion, less number of attempts, ease of threading, less incidence of complication, and also in obese patient. Next slide. These are the references for comparison of both. Thank you.
What is the difference between anterior and posterior approach of IJV insertion?
In anterior approach, we see the apex, both head of sternocleidomastoid and clavicle. It form apex. From there, at 30 degree, we insert the needle towards ipsilateral nipple. In posterior approach, we see external jugular vein at posterolateral border of sternocleidomastoid, and from there we insert the needle towards suprasternal notch.
Okay. What are the complications of IJV insertion?
First of all, hematoma formation, then pneumothorax, hemothorax, thrombophlebitis, carotid artery puncture.
Okay, fine.
Thank you.
Next, we have Dr. Vibhakar Vasudev.
Hello.
Are you ready?
Yes. Good evening, everyone. Myself, Dr. Vibhakar Vasudev, third year resident from Sumandi Vidyapit. So, title of my study was an observation study to compare epidural tramadol and epidural fentanyl for postoperative analgesia in lower limb orthopedic replacement surgeries. Next. Introduction. Pain is nowadays considered as sixth vital sign in postoperative monitoring. Various adverse effects are associated with postoperative pain. By definition, pain is an unpleasant sensory and emotional experience associated with actual and potential tissue damage or described in terms of such damage. The pain is a subjective phenomenon, so perceived only by sufferer. Conventionally, opioids or NSAIDs are used, but there are certain side effects and disadvantages of using these. For postoperative pain management, epidural is more effective than these conventionally used drugs. Next slide. So there are some benefits of using epidural analgesia that are good analgesia, good pulmonary function, less cardiac ischemic event, early mobilization, and increased bowel movement. So in my study, we use two opioids, tramadol and fentanyl. Tramadol is a weak opioid and centrally acting, whereas fentanyl is highly lipid soluble and similar to mu1 and mu2 receptor. Next. So aim of my study was to compare the postoperative analgesia efficacy of epidural tramadol and epidural fentanyl in lower limb orthopedic replacement surgeries. And the objectives were to compare onset and total duration of analgesia, to compare the quality of analgesia, and to compare the incidence of side effect in both the group. Next. In material and methodology, after approval from Institutional Ethical Committee, 58 patients were selected and they were divided into two equal groups randomly, and whole procedure were explained to them and consent was taken. In group T, patient received 1 mg per kg of tramadol diluted in 10 cc, whereas in group F received 1 microgram per kg of fentanyl diluted in 10 cc in normal saline. My inclusion criteria was patient ASA grade 1 to 3 undergoing lower limb orthopedic replacement surgery and age between 18 to 65, whereas exclusion criteria were patient refusal, having severe systemic disease, pregnant, local infection, coagulopathy, vertebral anomalies, neurological diseases, ASA 4 and above, and age less than 18 and more than 65. Next. Intraoperatively, epidural catheter was introduced in L2, L3 space, and subarachnoid block was given in L3, L4 space, and bupivacaine 0.5% heavy drug was given. Next. My main study was postoperatively. Postoperatively, patient was shifted to recovery room, and it was observed in in time interval at 0 hour, 4 hour, 8 hour, 12 hour, 18 hour, 24 hour, 4, and 48 hour after zero dose. And parameter observed were VAS score, sedation score, BP, frequency of epidural dose, onset of analgesia, duration of analgesia, and side effects. Next. So here are my results. The mean age in group T, group tramadol was 49 and weight was 62. And group F was age was 49 years and weight was 59 kg. Next. So onset of analgesia in group T, the range is between 9 to 18 minutes and mean time was 12.47 minutes. And group F was 3 to 10 minutes and the mean was 6.15 minutes. Next. Quality of analgesia was checked by VAS score. In this graph, we can see that VAS of fentanyl was significantly lower throughout the study. This graph represents the quality of analgesia and it was better in group fentanyl. Next. Duration of analgesia. Duration of analgesia in group tramadol was 8 hours and range was between 6 to 12 hours, and group fentanyl, the mean was 5.4 hours and the range was 4 to 8 hours. Epidural top-up requirement are noted, and it was noted that top-up requirement in group fentanyl was higher with respect to group tramadol throughout the study. Next. Here is the number of top-up required per patient in 48 hours. Here we can see that top-up required in group fentanyl was between 3 to 6, and whereas in fentanyl it was higher between 4 to 9 throughout the study in 48 hours. Next. This is representation of top-up requirement in both the patients. Red for fentanyl and blue for tramadol. Next. Sedation score was calculated. It was noted that sedation score 2 in 97.8% patient and sedation score 3 in 2.2% patient in group tramadol, whereas 86.5% and 13 is 2 and 13.5% is 3 in group fentanyl. Next. Side effect in both the group, vomiting and nausea was noted, whereas in nausea vomiting, incidence of nausea and vomiting was higher in group tramadol, and pruritus was noticed only in group fentanyl. Next. So in dissection, orthopedic procedure is one of the most painful procedures. A combined spinal plus epidural technique can be used where catheter is kept in situ for postoperative analgesia. In our study, we compared two drugs and p-value was calculated. First is for time of onset of analgesia. P-value calculated was statistically significant between the group. Onset of analgesia was faster in fentanyl. Duration of analgesia, it was statistically significant. Duration was higher in drug tramadol. Next. VAS score calculated was lower in group fentanyl. It was statistically significant throughout the study, and we noted that the top-up requirement of group fentanyl was higher with respect to group tramadol because of its lower duration of action. And sedation score was slightly higher in group fentanyl, but it was comparable. P-value was insignificant. None of the patients required any medical treatment. Next. So, from my study, we can conclude that fentanyl is having better quality of analgesia, early onset of analgesia as compared to drug tramadol. But due to its shorter duration of action, fentanyl frequency of top-up required is high. And sedation score in both the group was comparable, but slightly higher sedation in some patients in group fentanyl. Whereas, come to side effect, there are nausea and vomiting are present in both the group. Nausea and vomiting are higher in group tramadol, but pruritus is seen only in fentanyl group. Next. These are my references. Thank you.
Which are other different methods of pain relief, post-operative pain relief?
Actually, pain relief, spinal itself is a. If we give spinal relief itself act as a it can use a post-operative analgesia. We can add adjuvant for longer duration of post-operative analgesia. Second is we can give IV drugs, IV NSAIDs and opioids can be given, and patient control analgesia (PCA) can be given. Continuous infusion can be started in epidural catheter. These are some other methods.
Okay.
So, ma'am, we are done with all the presentations here.
Yes. Give me some time.
Yeah. Okay.
Just 3-4 minutes. I am sending you a result.
Okay.
have sent you.
Okay, ma'am. So should I announce right now or should I WhatsApp it?
Whatever is feasible to you. Doesn't matter to me.
I'll announce it right here. First position goes to Kinjal Solanki. Second goes to Shweta Patel. And third goes to Farista Begu.
Congratulations to all.
Thank you, ma'am.
Thank you.
Thank you, Dr. Manu Ramani, ma'am, for being with us today. Thank you.
Ma'am, would you like to say a few words to the participants?
All participants have done very nicely, but some comparison has to be done, and according to that, I congratulate all the winners and wish you all the best for your future. Thank you. Thanks to the organization.
Thank you, ma'am. Okay, so we conclude the paper presentations here. Thank you, everyone, for being here.
Thank you.
All the winners and wish you all the best for your future. Thank you. Thanks to the organization.
Thank you, ma'am. Okay, so we conclude the paper presentations here. Thank you, everyone, for being here.
Thank you.